Right, because I sincerely apologize for this unwanted interruption in between, but probably the system was on right from the morning and I forgot to switch off everything in the break time also. So probably the system was lagging behind. Anyways, let us come back to our previous discussion what we were talking about. Yeah. Fine. Let us re-understand the story. Now herein, this what we are seeing here. Or let us read these ulcers all together again. Suppose this is the epidermis and this is the dermis, right? Now, ulcer, we know this is simply breach in the continuity of epithelium or the mucous membrane. So, if this area is breached, that is what we call as a ulcer. Now, beta, we know that the ulcer, suppose we are talking about an ulcer somewhat like this. Now, this type of an ulcer, what we are seeing here, this is the sloping edge of the ulcer, which we see in cases of healing ulcer or inflammatory ulcer or a venous ulcer. Sometimes the edges of the ulcer may be somewhat like this. Now, this what we are seeing, beta, this is just the opposite. So here, this edge of the ulcer is a undermined edge. This is seen in tuberculosis or pyoderma gangrenosum type of story. Then we might see the ulcer edges somewhat like this. This sharp cut what you're seeing, beta, this sharp cut what you're seeing, this is something we can call it as punched out edge. This sharp straight line what you're seeing here, this is a punched out. This is something what we see in cases of syphilis. Right. Let me just check whether everything is all right, audio and video. Right. So this punched out type of edge is seen in cases of syphilis. As a doctor, when you are working in the hospital, just by looking at the edges of the ulcer, you can have an idea that what pathology you are actually dealing with. So if we try to take a look at something else also here, suppose I say that ulcer is somewhat like this, wherein there might be rolled out and beaded edges. Now, rolled out and beaded is something like this, beta. Now, suppose this is it, and here you see some beaded pearls. This bead what you are seeing here, pearl type of thing. This pearly edge or the beaded edge is seen in basal cell carcinoma. And sometimes, beta, in squamous cell carcinomas, we see this type of edge. This is raised and everted. It is not a classical bead or a pearl like, but this is a raised and everted edge. Raised and everted. Now this is squamous cell carcinoma. So just by looking at the edges of the ulcer, we can have an idea whether we are dealing with a healing inflammatory venous ulcer, or we are dealing with a tubercular ulcer, or a syphilitic ulcer, or it is a basal cell carcinoma, or it is a squamous cell carcinoma, right? So herein, if we take a look, the sloping or the shelving edge of the ulcer beta, this is something what we commonly see in cases of healing ulcer, healing or inflammatory ulcer, or we can say it as venous ulcer. While undermined edge, what you're seeing here beta, this is seen mainly in cases of tuberculosis. And this was the question asked on 4th of June. They gave a clinical scenario, they gave an image, that was a dermatology question, but yes, they mentioned that the edge of the ulcer is undermined. So they asked in which disease do we see this type of picture, and the answer was tuberculosis. Then there can be a punched out edge, which we commonly see in cases of syphilis. Then there is a rolled out and beaded edge, which we commonly see in basal cell carcinoma. Basal cell carcinoma. Or you can say a rodent ulcer. Rodent ulcer. This bead-like edge, what you are seeing here, this bead, pearly edge, this is seen in basal cell carcinoma or rodent ulcer. And raised irregular everted edge is seen in squamous cell carcinoma. Raised irregular everted edge is seen in squamous cell carcinoma. So beta, let us quickly try to revise these different edges, and I hope the audio would be a little better now. Earlier I think I received a message that probably I need to adjust my mic. Thank you, beta. The mic was actually inside, right? Okay. So let us quickly revise the edges of the ulcer. If you see a sloping type of edge, that means it's a healing inflammatory or a venous ulcer. If you see an undermined edge, this is tuberculosis. If you see a punched out edge, this is syphilis. If you see the rolled out beaded edge, this is basal cell carcinoma or a rodent ulcer. And if you see raised and everted edge, this is a squamous cell carcinoma. Let's do it once again, beta. Sloping edge, healing inflammatory venous, undermined TB, punched out syphilis, rolled out beaded basal cell carcinoma, rodent ulcer, raised everted squamous cell carcinoma. Now, if we just remove this from here and let us try to do it, beta. Yes, sloping edge, this is seen in healing inflammatory or venous ulcer, undermined in TB, punched out in syphilis, rolled out beaded in basal cell carcinoma, rodent ulcer, raised everted in squamous cell carcinomas. Right. Can you tell me, beta, can you speak out from your vocal cords? Sloping edge, undermined, punched out, beaded, rolled out, raised everted. Wonderful. Very well done. That's really good. Right. Now let's move a little further and see something else in the surgical wounds topic. Herein, there is something called as sinus and fistula. Now these words are so commonly used in various clinical subjects, beta. Sinus is a one-sided affair and fistula is a both-sided affair. When, suppose here in this particular picture, beta, if suppose I say that this thing what you're seeing, suppose I say this is the skin, wherein there would be, suppose the dermis here, and then suppose there is subcutaneous fat, and then suppose there is a muscle underlying, and beneath this muscle would be the bone. Right? Suppose this is the story. Now sometimes what can happen, beta, there might be one-sided connections developing with the skin. There may be a hole in the skin here, and then there is a tract which may be going somewhat like this. This is a one-sided affair. It is not getting connected to anybody else down. There is just an opening in the skin in this area. So this is a one-sided affair with the skin, which we call as a sinus. However, sometimes we may find a both-sided affair. That means there is a relation between two people. Like here, there is a connection with the skin, and down there might be a connection with some other structure. Right? So this connection with some other structure is called as fistula. If we just try to understand in Hindi बेटा, जब रिश्ते एक तरफा होते हैं उसे साइनस बोलते हैं, और जब रिश्ते दोनों तरफ से होते हैं उसको फिस्टुला बोलते हैं। जैसा कि हम जानते हैं, हमारे समाज में जो ये एबनॉर्मल रिश्ते होते हैं, इनकी कोई जगह नहीं होती। डॉक्टर होने के नाते जब भी ऐसे रिश्ते दोनों तरफ से कहीं बॉडी में देखे जाते हैं तो हम इन्हें एबनॉर्मल मानते हैं और इनको उड़ा देना ही ठीक समझते हैं। I repeat this story in English, beta. Sinus is simply a one-sided affair with the skin. Fistula is a connection between two people. And if we talk about different fistulas in the body, these are abnormal relationships. And as we know, there is no future of abnormal relationships. As a doctor in clinical practice, whenever you find these abnormal relationships between two people inside the body, it's better to chop these relationships off, separate the two people, repair the two people separately. We use these words quite commonly, like sinus. One simple example I would like to give you about a pilonidal sinus. Now, pilonidal sinus, beta, this is also called as Jeep's disease. Jeep's disease. क्या बोलते हैं बेटा इसको? What do we call this? Jeep's disease. Those individuals who keep on sitting for long periods. Sometimes what happens, beta, in those individuals, like if you're sitting for long periods, and suppose the seat on which you are sitting is that is hard. Most often, this is seen in the age group of 20 to 29 years. 4 times more common in males, those who have got a hairy gluteal skin. Now, what can happen, beta, in these individuals? For example, just imagine that this is the intergluteal cleft, right? So, this is the topic, beta, which we will be discussing in adult surgical problems. This is going to be the last topic in adult surgical problems. Now, herein, what we are able to see, beta, those individuals who are sitting for long periods, what can happen? Especially males 20 to 29 years of age group, hairy gluteal skin, the hairs will keep on rubbing the skin of the intergluteal cleft. As we can make out, beta, this what you are seeing, this line, this is the intergluteal cleft. That is the area between the two hips, right? Now, if suppose this skin is hairy and somebody is sitting for long periods, these hairs, they will keep on causing irritation to the skin. So there will be irritation to the skin here, and gradually what will happen? Abrasions will develop in the skin. The hairs will become dead. The tip of the dead hairs, beta, the tip of the dead hairs, that will create some hole into this area. That will create some hole in this area. And gradually what will happen? This dead hair will try to burrow through the skin here. And it will try to create a tract inside, beneath the skin into the subcutaneous tissue. And gradually one hair will go through this tract and will settle into the subcutaneous tissue. एक बार एक बाल अंदर जाता है तो ये अपने बाकी दोस्तों को भी बुला लेता है, अंदर आ जाओ, अंदर अच्छा है, बाहर कहाँ रगड़ खा रहे हो. Basically, if one hair goes inside in the subcutaneous tissue, it starts calling its other friends that why you are getting troubled outside. Come inside. Inside, it's cool, right? So gradually what happens? gradually hairs after hairs after hairs, they keep on migrating through this tract, and a tuft of hair settles in the subcutaneous tissue. Now here in the subcutaneous tissue, this is the foreign body. It will create a foreign body reaction and will lead to some abnormal discharges coming out from the skin of this region. This is what is a pilonidal sinus. It is just a one-sided opening with the skin. The other end is blind in the subcutaneous tissue. While fistula, fistula is something which we keep on talking at so many places. For example, if suppose we talk about something like this. Now here in beta, if we just try to focus on one condition called as fistula in ano or anal fistula, we are just trying to understand what is the difference between a sinus and a fistula. You know beta, the anal canal is a dirty area, right? So many times infections occur in the perianal region, and sometimes what happens, abscess can form in the perianal region. Now, if you carefully take a look, can you appreciate this abscess in the perianal region? You can very well understand and imagine that how painful this condition is going to be. Many times, these patients are quite shy. They do not report to the doctor in the hospital. And the abscess inside, the pus inside keeps on increasing. For example, if I say that this, what we are seeing here, this is the anal canal. Right? And there is an abscess developing in this particular area, in the perianal area. Now, if the patient does not come to the doctor and this abscess is not treated, the abscess will keep on increasing in size, and a day will come when this abscess might rupture. If the abscess ruptures, inside it can rupture into the anal canal, and outside it can rupture into the perianal skin. If this happens, beta, there is an abnormal relationship developing between the skin outside and the anal canal inside. That means this is what is a fistula in ano. Abnormal relationship between two people, abnormal relationship between the skin and the anal canal, right? The treatment for any fistula, we need to just chop that fistula off. We keep on studying about different fistulas like vesico-vaginal fistula. Vesico-vaginal fistula, beta. Vesico is bladder. When abnormal relationship develop between the urinary bladder and the vagina. For example, obstructed labor. If just imagine that normal vaginal delivery is taking place, and suppose the baby's head is too large, and when the baby was coming out from the vagina, suddenly you find that the baby's head is getting stuck at the outlet, at the vaginal outlet. Now this is going to put pressure on the structures beneath the vagina. This may cause necrosis of the structures beneath, and this may result in an abnormal relationship developing between the urinary bladder and the vagina, which we call as vesico-vaginal fistula. How these fistulas can present, beta? Like if we talk about fistula in ano, you can very well understand whatever saman is coming from this rasta, whatever contents are coming from this rasta, these contents can also be coming out from this rasta. Right? So patient may present with fecal discharge coming out from this sinus opening. Patient may even present with some flatus coming out from this fistulous opening, not the sinus, fistula opening, right? Same way in case of vesico-vaginal fistula, beta, abnormal relationship between bladder and vagina. So whatever is there inside the bladder, that will start coming out through the vagina, right? So in the treatment, we have to chop those fistulas, we have to repair the vagina separately, we have to repair the bladder separately, and that is how these are treated. We talk about arteriovenous fistulas, AV fistulas, that is an abnormal relationship between artery and the vein. Which has got more pressure, beta? Artery has more pressure or vein has more pressure? Obviously, artery has more pressure. So if there is a relation between artery and vein, blood will move from artery to vein or vein to artery? Yes, you're right. Artery to vein. So more blood will be coming into the vein. And whenever more blood comes into the vein, because the vein wall is weak, it is not able to tolerate such high blood flows. So it becomes abnormally dilated and tortuous. And that is what we call as varicose. Okay, fine. There is another fistula which we call as tracheoesophageal fistula. That is an abnormal relationship developing between the trachea and the esophagus, right? Fine. So just to give you an idea that since we are going to use these terms sinus and fistula so often, we should have a clear thought in our mind that what actually these things mean. So if we just try to compare the sinus and fistula, sinus is a blind ending tract which is communicating with the skin, and this is lined by granulation tissue. This is lined by granulation tissue. While fistula is abnormal communication between two epithelial lined surfaces. Epithelial lined surfaces. And this fistula itself is lined by granulation tissue. Fistula itself is lined by granulation tissue. The classical examples, pilonidal sinus, which we call as Jeep's disease, and here for fistula, fistula in annum, right? Okay. Then we have got something like sebaceous cyst, which is mentioned here. This can be an image-based question. As you can see in the scrotum, there are a lot of cystic swelling seen. So these are actually the sebaceous cysts. These occur in the sebaceous glands. Many times, beta, suppose I say that here what you're seeing, suppose inside there is a sebaceous gland. Now, this gland would be having some duct also, beta. Suppose this is the duct of sebaceous gland. So the sebum would be coming out here. Sometimes what can happen, beta? There might be some traffic jam situation in this area. And if there is a traffic jam, then this sebum will not be able to come out. So all this sebum is going to be trapped inside. And this collection of sebum inside might cause a cystic story, something like this. And this is how the sebaceous cyst can occur. We should know, beta, that sebaceous glands are absent in the palm and the sole. So we don't find sebaceous cyst over the palm and the sole. कहाँ पे नहीं मिलती बेटा sebaceous cyst? Palm and the sole. We don't find sebaceous cyst, right? They're typically absent on the palm and the soles. They're commonly seen over the scrotum. So this is all about this particular chapter, beta. Let us quickly revise this chapter, first with the workbook and then without the workbook. In this surgical wounds chapter, beta, we talked about the different type of surgical wounds. Depending on the amount of infection in a particular surgery, we can classify these surgeries into 4 categories. No infection, minimal infection, significant infection, gross infection. No infection, clean. Minimal infection, clean, contaminated. Significant infection, contaminated. Gross infection, dirty. Surgeries like hernia, thyroid, and breast, generally there are no microorganisms inside in these areas, so the chances of postoperative infections are minimal. We don't need any antibiotics in these category of surgeries, that is clean surgeries. While clean, contaminated, and contaminated, that is class 2 and class 3, if we focus on GIT, we know that there are a huge number of bacteria in our GIT. Whenever we are doing elective GI surgeries, there is a risk of small amount of infection developing. So we give prophylactic antibiotic, preferably 20 to 30 minutes before the surgeon makes the incision, that is at the time of induction of anesthesia, to minimize the incidence of post-operative infection. Elective cholecystectomy, elective appendicectomy. These, if you are planning these surgeries, obviously the bacterial party will not be much. Class 3 or contaminated, emergency GI surgery. When you are doing surgery in the GIT, and especially when there is acute inflammation, when there is a huge bacterial party going on inside, then the chances of infection will definitely be high. In these cases, we give the antibiotic before surgery, that is the same 20-30 minutes before starting the surgery. And we also give therapeutic antibiotics, that means after the surgery, just to reduce the bacterial population. Dirty is something which is having pus. Whenever we are doing any abscess drainage, whether it is just a simple incision and drainage for a superficial abscess, we are dealing with huge amount of bacterial population. The chances of infection are very high. We have to give both prophylactic as well as therapeutic antibiotics. Just a reminder that whenever we are doing any surgery, we usually do not want hairs at the operative site. The best thing what we can do is we can use hair clippers just before starting the operation, so that there is minimal chance of bacterial growth. Right. Keloid and hypertrophic scar. This is simply overgrowth of collagen and fibroblast. If the story remains confined within the limits of the original wound, it is hypertrophic scar. If the story extends beyond the limits of the original wound, that is a keloid. Usually this extension is in a claw-like manner. Keloids are more commonly seen in blacks, Afro-Caribbean people, more commonly seen in females. Hypertrophic scar can resolve spontaneously, but keloids generally do not resolve spontaneously. These keloids and hypertrophic scars, they are more common in those areas of the body where God has given less amount of soft tissue. That means the sternum, or maybe the tip of the nose, earlobe, or the tip of the shoulder. Since hypertrophic scar can resolve spontaneously, no active treatment is required. We just want to keep the scar moist so that cracks do not develop and chances of microbacterial invasion is less. So we ask the patient to apply some coconut oil or maybe moisturizing cream like Fair and Lovely. While in a keloid, since they do not resolve spontaneously, we give intrakeloidal injection of triamcinolone. And generally we give 3 to 6 injections at an interval of 21 days. If the keloid still persists, then we do surgical excision and we put some radioactive seeds in the bed of the keloid, which is called as interstitial radiotherapy. Then we talked something related to the edges of the ulcers. Just by looking at the edge of the ulcer, we can get an idea that what pathology we are dealing with. If we find a sloping edge, that means it's a healing inflammatory or a venous ulcer. If we find an undermined edge, TB and pyoderma gangrenosum, punched out syphilis, rolled out beaded, basal cell carcinoma, rodent ulcer, raised, irregular and inverted, that is in squamous cell carcinomas. Right. Then we talked something about sinus and fistula. Sinus is a one-sided affair with the skin, while fistula is an abnormal relationship between two people. The classical example is a pilonidal sinus, Jeep's disease. Here, fistula in ano, vesicovaginal fistula, arteriovenous fistulas, tracheoesophageal fistulas. Sinus is a blind ending tract communicating only with the skin, lined by granulation tissue, while fistula is an abnormal connection between two epithelial lined surfaces and the fistula itself is lined by granulation tissue. Sebaceous cysts are absent over the palm and the soles, commonly seen over the scrotum. Right. Now, if we just try to remove this iPad and try to revise the surgical wounds quickly, beta. What we discussed in this surgical wounds, let me just magnify myself and come right in front of you. Okay, fine. So the revision of surgical wounds, we can classify the different operations into 4 categories, beta. Clean, contaminated, and dirty. Clean, where there is no infection. Clean, contaminated, minimal infection. Contaminated, significant infection. Dirty is gross amount of infection. Surgeries like hernia, thyroid, breast, there is no microorganism inside these areas, so the chances of infection are almost minimal. There is no role of antibiotics to be given in these clean operations. However, clean, contaminated, and contaminated, that means class 2 and class 3, they are commonly in reference to GI surgery. We know GIT is having a lot of bacteria inside the lumen in the intestine. So whenever we are doing surgery over the intestine, there is a risk of infection. However, if we are doing elective surgeries, planned surgeries, then the chances of bacterial population, what we are coming across, would be less. But when we are doing emergency surgeries in acute inflammations, then the chances of bacterial population coming across would be more. So there will be less chances of infection in elective GI surgery, more chances of infection in emergency GI surgeries. Cholecystectomy is generally done on elective basis. Appendicectomy is generally done on emergency basis. Elective cholecystectomy, elective appendicectomy would be an elective GI surgery, less amount of infection. While emergency cholecystectomy, emergency appendicectomy would be a significant amount of infection. Elective GI surgeries classified in class 2, clean, contaminated, and emergency GI surgeries class 3, contaminated. In minimal infection, that is class 2 clean, contaminated, we give prophylactic antibiotic 20 to 30 minutes before the surgeon makes the incision. That is at the time of induction of anesthesia. While contaminated surgeries, where the amount of infection is more, we have to give both prophylactic as well as therapeutic antibiotic before the operation as well as after the operation. Dirty surgeries, where we are dealing with pus or abscesses like incision and drainage for abscesses, huge amount of bacterial population would be there. We have to give both prophylactic and therapeutic antibiotics. Whenever we are doing surgeries, we want to remove the hairs from the operative site, and we use hair clippers just before the operation to remove these hairs. We are not doing any shaving, depilatory creams, or maybe waxing type of procedures, because they cause more abrasions, more blood, more bacterial population, and we don't give any much time before the operation for removing these hairs, because more the time you give before the operation, more will be the chance of bacterial proliferation, right? So we remove these hairs just before the operation, and the best thing is use of hair clippers. Then we talked something about hypertrophic scar and keloid, which is actually discussed nicely in pathology. In both hypertrophic scar and keloid, there is overgrowth of collagen and fibroblast. If the story remains confined within the limits of the original wound, that is a hypertrophic scar. If the story extends beyond the limits of the original wound, usually in a claw-like manner, that is a keloid. Spontaneous resolution is seen in hypertrophic scar, but not in a keloid. Keloid is more commonly seen in blacks, Afro-Caribbean people, more commonly seen in females. Common site for these hypertrophic scar and keloid would be the sternum. Any area in the body where God has given less amount of soft tissue. If there is any injury in that area, if there is any wound in that area, if you're doing any operation in that area, the body tries to produce more collagen and fibroblast in order to overprotect that area. That is why these hypertrophic scars and keloids are more commonly seen over the sternum. They can be seen even at the tip of the shoulder, maybe the tip of the nose, or maybe the ear lobule. Then we talked something related to the ulcers, the edges of the ulcer. As a doctor, just by looking at the edge of the ulcer, we can get an idea that what disease pathology we are dealing with. Sloping edge, seen in healing inflammatory venous ulcer. Undermined tuberculosis, pyoderma gangrenosum. Punched out syphilis, rolled out beaded basal cell carcinoma, rodent ulcer, raised everted squamous cell carcinoma. Then we talked about the difference between a sinus and a fistula. Sinus is a one-sided affair with the skin. Fistula is an abnormal relationship between two people. Sinus is a blind ending tract communicating on one side with the skin, and this sinus tract is lined by granulation tissue. Fistula is an abnormal connection between two epithelial lined surfaces, and the fistula itself is lined by granulation tissue. Example of sinus is a pilonidal sinus or Jeep's disease, which is commonly seen in those individuals who keep on sitting for long periods, common in the age group of 20 to 29 years, 4 times more common in males who have got hairy gluteal skin. Fistula examples: fistula in ano, vesicovaginal fistula, arteriovenous fistula, and tracheoesophageal fistula. Sebaceous cysts, they are absent over the palm and the soles, but they are commonly seen over the scrotum. Right. So this is the story about the surgical wounds. Now, beta, from here, let's move towards the vascular surgery story. This chapter, beta, this is a chapter which is discussed in dermatology. Now, if we come to this chapter number 4, page number 49, that is vascular surgery. Now, here in beta, I would just like to brief a few relevant things here. The different vessels what God has given to you in your body. God has given you arteries, God has given you veins, God has given you lymphatics. If suppose we just try to focus in the lower limb, suppose I say that this is what we are talking about, the lower limb area. Now, in this, we know that God has given the arteries, beta. Suppose here it is the femoral artery. This becomes the popliteal artery. Then popliteal artery will divide into anterior tibial and the posterior tibial artery. The anterior tibial would be going somewhat here. The posterior tibial will be going somewhat here. The anterior tibial artery is going to become the dorsalis pedis artery here, and the posterior tibial artery is going something like this. The job of the artery in the body, beta. What is the job of the artery? Now here, if we just try to understand this story, we all know, beta, that God has given us a pump, that is heart, to pump the oxygen to different parts of the body. We know that there is something which is coming out from the left ventricle. What do we call that? Yes, aorta. So this aorta comes out of the left ventricle. It ascends upwards, ascending aorta, arch of aorta, descending thoracic aorta. It pierces the diaphragm and comes in the abdomen as abdominal aorta. Now, in the abdomen, beta, suppose I say that this is the abdominal aorta. Now, this will divide into the common iliac, the right and left common iliac, and then this common iliac will further divide into internal iliac and external iliac. Internal iliac and external iliac. And this external iliac artery becomes the femoral artery. So here what we are seeing, this is the femoral artery. This becomes the popliteal. This divides into anterior tibial and the posterior tibial, and this anterior tibial continues in the foot as the dorsalis pedis artery, right? The job of the artery is to supply the oxygen to different cells of the body, right? Now, wherever the supply is going on, we know that this oxygen is going to get utilized. It will become deoxygenated, and then the deoxygenated blood has to come back towards the heart. So herein, if we take a look at the lower limb beta, in the lower limb, we would be having the deep venous system, we would be having the superficial venous system. Suppose here, we are not discussing in detail at this point about what is superficial and what is deep. We are just trying to understand the basic concept. Okay, so there would be veins which would be present here, and these veins would be bringing the deoxygenated blood, right? So here, suppose this is the popliteal vein, here this is the femoral vein, right? This is bringing the deoxygenated blood, and we know that God has given valves in the veins, and the direction of valve is such that they do not allow the blood to fall back. Whatever blood has moved up, that keeps on moving up, it does not come back because God has given the valves in the veins, right? Apart from this, whatever cellular metabolism is taking place, because of that metabolism of the cells, some amount of fluid would be leaking into the interstitial space, which we call as the interstitial fluid. So, God has also given us the lymphatic channels. And these lymphatic channels, they are draining the interstitial fluid. And these lymphatic channels, they are pouring their lymph into the lymph node, and that is how the lymph is also moving upwards. So beta G, if you focus on this, you have got these different vessels in your body: artery, veins, lymphatics. These are vessels. In vascular surgery, we are going to discuss the problems in these vessels, right? In surgery, beta, we try to create traffic jam situations in these vessels, and let us see what will happen in the patient. Okay? Suppose I say that there is a traffic jam developing in the artery. Look at me on the screen. Look at me, beta. If I say there is a traffic jam in the artery, what will happen to supply of oxygen, beta? No supply of oxygen. Or suppose I say that just a small traffic jam has started. That means the oxygen supply to the distal part has started decreasing. Whenever some area in the body is not getting oxygen, that area will start presenting with severe pain, right? So that is how the arterial obstruction patients can present to us. Obviously, we know that if the arterial obstruction continues, and if suppose a day comes when there is no supply to the distal part will become gangrenous. अगर आर्टरी में धीरे धीरे रुकावट डेवलप होना शुरू हो रही है, तो नीचे की ऑक्सीजन कम हो जाएगी ना, और अगर नीचे ऑक्सीजन नहीं मिलेगी तो फिर नीचे का जो हिस्सा है वो दर्द से चिल्लाएगा. अगर मान लो आर्टरी में ये ऑब्स्ट्रक्शन चलता रहा और एक ऐसा दिन आ गया जब नीचे के हिस्से को सप्लाई बंद ही हो गई, तो नीचे का हिस्सा सड़ जाएगा, गैंग्रीन हो जाएगा. और गैंग्रीन में हमें क्या करना पड़ता है? काटना पड़ता है. व्हाट इज द ट्रीटमेंट फॉर गैंग्रीन? एम्पुटेशन. एंड हु आर यू बेटा? यू आर द डॉक्टर, and you know what you are supposed to do. You cannot allow this gangrene to occur. And now if the patient comes to you early, you will try your level best You will try to find out ways here and there so that you can increase the supply of oxygen to the distal part. That is what we try to do in arterial obstructions. Right, Bitta? Fine. If I say that now let us talk something about the veins. Right? If suppose we try to create a traffic jam in the vein, now what will happen? The deoxygenated blood will not be going towards the heart. So all this blood is going to get pooled in this area. Pooling of blood in this area will lead to stasis. And stasis is an open invitation for the bacteria. So there may be a bacterial party, what we commonly see in cases of deep vein thrombosis. I repeat this, Peter. If suppose there is any traffic jam in the vein, if there is a traffic jam in the vein, blood will not be moving up. So all the blood will be getting pulled down in the vein. Stasis of blood in the vein, open invitation for the bacteria, and there will be a bacterial party here. Right? Okay. Same story in the lymphatic channels, Peter. If we create a traffic jam in the lymphatic channels, the interstitial fluid which was going up will not be going up now. All this fluid will get pooled in these lymphatic channels and there will be swelling. So this is going to cause swelling of the lower limb. Right? That is called as lymphedema. Right, Beta? This is just a brief outline that what we are going to discuss actually in vascular surgery. So, Beta, first what we'll do is, first we'll discuss about the arterial obstruction, right? There are two main topics here. One is a gradual obstruction, another is a sudden obstruction. Gradual means slowly and slowly, sudden means sudden, right? Okay. In the veins, we talk about superficial veins and deep veins. Pathology in the superficial vein commonly seen as the varicose vein. Pathology seen in the deep vein commonly it is the deep vein thrombosis. In the lymphatics, Beta, we see lymphedema, which can be classified into primary and secondary. So we'll talk about all these stories one by one, right? Now here, Beta, first let us imagine the story of gradual arterial obstruction. In this gradual arterial obstruction, now suppose this is the femoral artery, Beta, and then there is a popliteal artery, and then there is anterior and posterior tibial artery. Now, what is the commonest cause of this gradual arterial obstruction? It is atherosclerosis. Now, why this atherosclerosis occurs? For this, Beta, if we just try to understand the anatomy of the artery. Now, suppose, Beta, this is the artery. We know that God has given different layers in the artery. Suppose this hole is the artery. Now, here, this is the innermost layer of the artery. Suppose this is what we call as intima. And then behind the intima, we have got the muscle layer of the artery, or we can say it as media. And then there is a outer covering, which we call as the adventitia. right? So if we just try to focus here, beta, this is the intima, media, and adventitia. Atherosclerosis is simply deposition of cholesterol which starts taking place from the intima, right? Cholesterol means butter, मक्खन. मक्खन जमा होने लगता है बेटा आर्टरी की दीवार में, right? Now, if this cholesterol is getting deposited, initially it would be very small. For example, if we try to correlate this story here in this picture, suppose I say beta that there is a atherosclerosis developing in this particular area, right? What is going to happen to the patient? Now, just try to understand the concept better here. What is happening? As the atherosclerosis is taking place, starting depositing in the intima, here you can see the intima is having this atheromatous plaque. If you look at the caliber of the vessel, the vessel is not having too much of problem. It is not that the supply to the distal part is getting much affected, right? The supply is still taking place because there is good amount of lumen here. So the patient might not be having any complaints in this stage when the patient is at rest. But sometimes what happens, beta, as this plaque is depositing, there is at least some narrowing. कुछ तो narrowing हो रही है ना बेटा यहाँ पे. There is some narrowing which is taking place, right? So what happens in these stages? Patient does not have any significant symptoms at rest. But on exercise, suppose the patient is walking. Now when the patient is walking, at the time of walking, what is happening? The demand by the calf muscles is increasing. If somebody is walking, beta, the most bulky area in the lower limb is the calf. So maximum work is being done by the calf muscles. That means maximum demand is by the calf muscles. That means maximum oxygen is needed by the calf muscle. But if suppose there is any traffic jam here, if the calf muscles are not getting adequate blood supply, adequate oxygen, then the calf muscle will start shouting. They will start causing pain in the calf in this patient. This is what we call as intermittent claudication. क्या बोलते बेटा? What do we call this? Intermittent claudication. When the story has just started, patient may experience calf pain on walking a certain distance. Now, gradually, beta, what can happen? If suppose this plaque is increasing, that means there is more traffic jam developing inside the vessel. Initially what happened, beta? Patient experienced calf pain on walking. The distance which the patient is able to walk without any pain is called as claudication distance. Suppose patient was able to walk for 400 meters without pain, right? Then 400 meter will be called as claudication distance. At 400 meter, the patient started developing pain in the calf. If the disease is progressing, अगर ये plaque बढ़ रहा है, now what can happen? The patient may start experiencing calf pain even at lesser distance. Suppose the patient start developing calf pain at walking 200 meters. Right? So now 200 meters will be the claudication distance. And generally what we see, beta, there are gradings of this intermittent claudication. Calf pain on walking a certain distance. But on further walking, this pain is relieved. Now, why this calf pain can be relieved on further walking? Why pain occurs? Pain occurs because of accumulation of substance P. And when the person is walking further, what can happen? The vessels are getting dilated. And if the arteries are getting dilated gradually, then whatever substance P got accumulated, because of dilatation of the artery, the flow increases and the substance P is washed off. So in the starting, what happens? There is calf pain on walking a certain distance, but this pain is relieved on further walking due to washing of substance P. This is the grade 1. Gradually, what will happen? Patient experiences calf pain on walking a certain distance, but now the patient pain is not going. But still the pain is not that severe and the patient continues to walk with pain. Okay? Calf pain on walking, but patient continues to walk with pain. This is grade 2. If the disease progresses further, calf pain on walking, and now the pain is so severe that patient cannot walk any further and he has to take rest. This is grade 3. And if suppose the disease keeps on progressing, there may be a possibility that not only on walking, but even if the patient is at rest, then also adequate supply is not going and the patient may start experiencing pain in the most distal part. That is the foot. This is called as rest pain. Okay? So initially what happened, beta? When the plaque was small, the patient did not have any complaint at rest. But when the patient used to walk, then these calf muscles required more oxygen, which was not delivered. So there was pain in the calf. Initially pain in the calf, which improved pain in the calf on walking, which improved with further walking. Then pain in the calf on walking, but patient continues to walk with pain. Then pain in the calf on walking. Now the pain is so severe, patient cannot walk any further, has to take rest. If the disease progresses further, the supply has reduced drastically. So now the most distal part is not able to receive supply even at rest. This is what we call as rest pain. So rest pain is felt in the foot at rest. Intermittent claudication is felt in the calf on walking, on exercise. Intermittent claudication is not felt at rest. ध्यान रहेगा बेटा, simple है. Now suppose beta, if I say that the obstruction is further increasing, if the obstruction is further increasing beta, now what will happen? No supply, blood supply. So there will be some paresthesia type of thing seen here. Okay, paresthesia type of thing seen here, right? Gradually the patient will develop pre-gangrene and gangrene type of situation in the most distal part, right? So beta ji, just trying to summarize, just trying to understand once again that what actually happens in gradual arterial obstruction. Gradual arterial obstruction में क्या हो रहा है बेटा? When the plaque has just started developing, patient experience pain in the calf on walking. When the obstruction increased, patient started experiencing pain in the foot even at rest. When the obstruction further increased, this foot became cold, numb, and paresthesias were seen. Gradually, in the most distal part, pre-gangrene and gangrene developed. So these are the different stages of gradual arterial obstruction. Right? Let us just try to revise these different presentations of gradual arterial obstruction beta. Intermittent claudication, rest pain, coldness, numbness, paresthesia, pre-gangrene, gangrene. Can you speak out with me beta? Intermittent claudication, rest pain, coldness, numbness, paresthesia, pre-gangrene and gangrene. Intermittent claudication, rest pain, coldness, numbness, paresthesia, pre-gangrene and gangrene. Now can you say it, beta? Once again. Perfect. Very good. Intermittent claudication, rest pain, coldness, numbness, paresthesia, pre-gangrene and gangrene. This is what we can see in this particular patient. Right? Now, how we can grade the intermittent claudication? 4 things were there, beta, in Boyd's grading. Pain in the calf on walking, improves with further walking. Pain in the calf on walking, continues to walk with pain. Pain in the calf on walking, cannot walk, has to take rest. 4th, rest pain. Okay, so can we do this Boyd's grading, beta? Can you do it with me? Intermittent claudication grading. Pain in the calf on walking, pain improves with further walking. Pain in the calf on walking, continue to walk with pain. Pain in the calf on walking, now cannot walk, has to take rest. And 4th, rest pain. Right? So that is how we can grade this intermittent claudication. Now, beta G, in your clinical practice, February 23, the 4th of June 2022, there was a question related to this. They gave a clinical scenario that there was a patient who was able to walk for 400 meters initially, but now gradually we are seeing that he is not able to walk more than 200 meters, has to take rest. And now slowly and slowly what we are seeing, that patient has started developing pain in the foot even when he is at rest. So what is this? Whether this is intermittent claudication or rest pain. If the patient has started developing pain in the foot at rest, then obviously this is a rest pain, right? How you as a doctor are going to approach these patients in your practice? Whenever such ischemic symptom patients come to you, intermittent claudication, rest pain, coldness, numbness, or maybe pre-gangrene, gangrene, most important thing for us is to feel the pulses. To feel the pulses, especially if we are talking about the lower limb, beta, in the lower limb, as we can see here, we can feel the femoral pulse. We feel this just beneath the groin crease, that is 2 centimeters below the mid-inguinal point. And to feel these pulses, we put our 3 fingers over the artery and try to press these 3 fingers over the artery and try to press the artery against the bone. So we feel the femoral pulses 2 centimeters below the mid-inguinal point. For popliteal pulse, we turn the patient in a prone position and we flex the leg at an angle of 45 degree, and then we feel for the popliteal from behind, from this particular area. We try to feel the popliteal pulses from this area, that is from behind. Since popliteal artery is quite deep and there is no bony prominence near this popliteal, that is why it is the most difficult pulse to feel. We can feel the anterior tibial pulsations. The anterior tibial pulsations can be felt next to the tendon of extensor hallucis longus at the ankle. And posterior tibial pulse, again beta, this was an anatomy question asked on 4th of June 2022. This was a repeat question, a previous year question, where they asked, where do you feel for the popliteal pulse? So popliteal pulse is palpated between the posterior border of medial malleolus and the Achilles tendon, best felt at inversion of foot. For the dorsalis pedis, beta, we have to feel in the proximal half of the first metatarsal space. This is the proximal half and this will be the distal half. we should know that dorsalis pedis goes towards the sole in the middle of the foot. So if you have to feel the dorsalis pedis, you have to keep your three fingers in the proximal half, right? If by chance you keep your three fingers in the distal half of the foot, you will not be able to feel the dorsalis pedis. And this is something which is a common question we used to ask as students when we are taking the practical exams, the Viva exams. In the practical, suppose you get a case of peripheral vascular disease. Now the examiner wants you to demonstrate whether the dorsalis pedis is normal in the patient or not. You go towards the patient, the examiner is wearing these specs and he is carefully looking at you, that what you are actually doing. If you don't know where the dorsalis pedis is, and suppose you are keeping your three fingers in this area, the examiner is looking at you. You look at the examiner. Now, when you're looking at the examiner, there is an anxiety, right? And you start feeling your own pulsations. And then you say to the examiner, sir, I think dorsalis pedis is normal in this patient. Normal? Okay, come. And the examiner gives you one full year to know where you feel the dorsalis pedis. He gives you 1 year time. Come after 1 year, your exam is over, right? So this is something which is commonly used by the examiners. That is why it has a probability of being asked in the MCQs. What we did just now was, we just tried to know where do we feel the different pulsations in the lower limb. So femoral, 2 centimeter below the mid-inguinal point, popliteal in the popliteal fossa, anterior tibial next to the tendon of extensor hallucis longus, posterior tibial between the posterior border of medial malleolus and Achilles tendon at the inversion of foot, and dorsalis pedis in the proximal half of the first metatarsal space. Now, Bitaji, tell me one thing, that if there is an obstruction here, right, beta. Now you just tell me, beta, if there is an obstruction at this level, or suppose I say there is an obstruction at this level. Okay, suppose I create an obstruction at this level. Suppose I create an obstruction at this level, beta, right? What do you expect the nature of pulse below the obstruction? Will it be low volume or will it be high volume? Below the obstruction, blood कहाँ से आ रहा है बेटा? Blood is coming from above. So below the obstruction, less amount of blood is coming. So there will be less pressure in these vessels and the nature of pulse will become low volume or feeble. Or sometimes the distal pulses may even be absent. Right? What will happen above the obstruction? Now, above the obstruction, in this particular area, there will be turbulence. And here, if you try to feel for the pulse, it will be high volume. So, below the obstruction, low volume. Above the obstruction, high volume. Just by your three fingers, beta, just by your three fingers, index, middle and ring finger, you are able to know what can be the site of obstruction in this patient, right? Sometimes what happens in long standing, or if the disease process is very slow, if the atheromatous plaque is developing slowly and slowly, what can happen, beta? Suppose I say that this is the plaque which is developing slowly and slowly. there is a possibility that body can start forming the bypass channels around the obstruction. Body can start forming the bypass channels around the obstruction. Now, if this type of patient comes to you in clinical practice, patient might be complaining of some ischemic symptoms in the lower limb. When you are examining this patient, you feel that this pulse is normal. There is an obstruction here, but look, there is a collateral. There is a bypass already developed. Because of this bypass, the blood would be migrating through this collateral and going down. So this pulse will be normal. Because of the collateral, blood is coming here, here, here. So these pulses may be absolutely normal. But the patient is telling about some ischemic symptoms. So you don't think that patient is actually malingering. कभी कभी ऐसा हो सकता है बेटा कि ट्रैफिक जैम है आर्टरी में, लेकिन लंबे समय से ट्रैफिक जैम था, तो बॉडी ने अपने आप उस ट्रैफिक जैम के अराउंड एक बाईपास चैनल बना दिया, एक कोलेट्रल बना दिया, तो ब्लड जो है वो उस कोलेट्रल से नीचे आ सकता है. अगर पेशेंट अपने को इस्चेमिक सिम्टम्स बता रहा है और हम जब एग्जामिन कर रहे हैं तो हो सकता है हमें फेमोरल भी नॉर्मल मिल रही है, पोप्लीटियल भी नॉर्मल मिल रही है, एंटीरियर पोस्टीरियर टिबियल भी नॉर्मल मिल रही है, डॉर्सल स्पीडिस भी नॉर्मल मिल रही है. तो हमें एकदम से ये नहीं सोचना चाहिए कि पेशेंट नाटक कर रहा है. हमें what thought should come to our mind is कि probably the collateral has developed. That is why the distal pulses are feeling normally. Now, we understand that these collaterals or these bypass channels, these will not be as wide as the main channels, right? So, these collaterals are sufficient enough to bring the blood down when the patient is in a resting state. If we ask the patient to do exercise, then the demand below will increase and this bypass channel will not be able to meet up the increased demand. And if this bypass is not able to meet the increased demand, then when you examine these pulses will be absent or these pulses will disappear. This is called as disappearing pulse. जादू हो गया. पहले तो pulse मिल रही थी. Now you ask the patient to, initially you were able to feel the pulse. Now you ask the patient to exercise or walk in the hospital corridor. You are exercising the patient. Because of exercise, the demand is increasing and these small bypass channels will not be able to meet up the increased demand. So they are not able to supply blood because of increased demand here, and then these distal pulses will disappear. This is called as a disappearing pulse. This is because of collaterals. Now you come to know that yes, there is a problem. You ask the patient, okay bhaiya, ho gaya, now you please take rest. Now when you ask the patient to take rest, again the blood flow starts from these collaterals. Again the pulse reappears. Okay, so this is one small story what we should remember when we are examining the pulses. Okay, suppose in your clinical examination only, if you keep a stethoscope above the obstruction is here, right? If you keep the stethoscope proximal to the obstruction, above the obstruction, then you will hear a brew type of sound. Brew is basically a whoosh type of sound. This is what we call as brew. If on auscultation, beta, you hear this brew type of sound in a patient, if on auscultation you hear this brew type of sound, this simply indicates there is some turbulence. And this turbulence is most likely because of some stenosis or obstruction, right? This is just like when you are giving water to the plants with a pipe, right? Just imagine you are giving water to the plants with a pipe when you're watering the plants with that pipe, nobody knows what happens inside you. You try to squeeze the pipe, and then you hear a noise, and then you feel satisfied. Why that noise? Because as soon as you try to squeeze it, there was turbulence of water inside that pipe which created the noise. I repeat this explanation in Hindi, beta. मुझे पूरा विश्वास है कि आपने कभी ना कभी अपनी जिंदगी में पौधों को पानी जरूर दिया होगा, उस पाइप से, उस लेजम से। जब वो पाइप अपने हाथ में आता है तो ना जाने मन में कौन सा विचार आता है, ऐसा मन करता है उस पाइप की गर्दन दबा के देखें क्या होता है। और जैसे ही आप उस पाइप की गर्दन दबाते हैं, एक आवाज आती है और आपको एक अलग ही अनुभूति का एहसास होता है। ये आवाज क्यों आई? क्योंकि जब आपने उस पानी में रुकावट डालने की कोशिश की तो वहां पे एक टर्बुलेंस पैदा हुई। The same concept applies in the pipeline inside the body. This is the pipeline of blood. If you are trying to create an obstruction here, there will be turbulence, and if you keep your stethoscope here, you hear that brew sound proximal to the obstruction. So this is one thing which can definitely give you an idea that yes, there is a traffic jam situation in the artery. So beta, what we are doing in a peripheral vascular disease patient, we are doing our clinical examination. We have to examine the different pulses. Just by examination of the pulses, we can come to know where the pulse is low volume or feeble and where the pulse is high volume. Right? So you can come to know about the site of obstruction just by knowing the feeble and the normal volume pulses. Sometimes we get a disappearing pulse that is because of the collaterals. And sometimes we can hear a brew on auscultation. And brew simply indicates there is a distal obstruction in that artery. A very important thing in our clinical examination is we can compare the pressure in the artery at the level of ankle versus pressure in the artery in the arm. Normally, beta, right now you are you're sitting, right? So what is the, suppose I ask you, what is your blood pressure? So what is your blood pressure, beta? 120 by 80. What is your systolic pressure? 120. What is your diastolic pressure? 80. Now suppose, beta, you are taking the pressure here in the arm and systolic pressure here is 180, right? If suppose you are taking pressure at the ankle here, right now in you, beta, what should be the pressure at the ankle, systolic pressure at the ankle here? Ideally, it should be 120. If you are sitting, beta, maybe because of gravitational pull, the pressure may be slightly higher, maybe 126 or maybe 130 here. That means if you calculate the ratio of pressure at the ankle versus pressure at the arm, normally 120 here and 120 here. So the ratio should be 1. How do we measure this pressure, beta? If you just take a look at this, I'll just remove myself, I'll just try, or I'll take myself on this side and here in beta. This is what we are doing is, we are trying to measure the pressure at the ankle level. This what you're seeing is the sphygmomanometer cuff. This is the manometer. This instrument is a handheld Doppler. This is the pencil of the handheld Doppler. Like this is the instrument what you're seeing here, beta. This is the handheld Doppler and this is the pencil of the Doppler. And in this pencil, this is the tip of the pencil. Now what you're doing in this, you have kept the tip of the pencil here, right? and you're just trying to feel for the pressure at the ankle. And you will compare this pressure with the pressure at the arm. Okay? So suppose beta I say that if we calculate the ankle brachial pressure index, in this ankle brachial pressure index, this is the ratio of systolic blood pressure at the ankle versus systolic blood pressure at the arm. You said beta that your pressure at the ankle is 120 and your systolic pressure at the arm is 120. So what is the value of this ratio beta? The value of this ratio is 1. You also said that when you are sitting or standing, the pressure may be 130 by 120. That means slightly more than 1. Right? So this is also something which is normal. Okay. Now look at me carefully, beta. Look at me on the screen. Now what we are going to do, we are just trying to understand what is going to happen in this arterial obstruction story. What is going to happen in this arterial obstruction story? So in this particular case, no, there's something wrong. Just a minute. Yeah. Move this rather than moving my chair. Yeah. Now here what is going to happen, beta? If there is a traffic jam in the artery, the intravascular volume going here will be less. So pressure here will be less. Depending on how much is the obstruction, based on that, the intravascular volume going here will also decrease. So is the pressure. Now just tell me beta, if suppose there is less obstruction and suppose the pressure here is 90 millimeter of mercury, while pressure at the arm, that is 120. So the ratio will decrease. If suppose there is more obstruction here, the pressure here may be around 60 millimeter of mercury or 50 millimeter of mercury. Now in this case also, the ratio is decreasing. If there is more obstruction, then the pressure here might be say 40 millimeter of mercury. More obstruction, the pressure here might be 20 millimeter of mercury or 10 millimeter of mercury. So just by calculating the ratio of ankle pressure versus the brachial pressure, you can come to know what is the severity of obstruction. This is ABPI, and this instrument what you're seeing beta, this image has been asked in your exams. This image has been asked in your exams. December 2019, there was an image and they asked that what you are doing in this picture. Are you doing any nerve study, or you are doing any muscle study, or you are doing any blood pressure study? So the answer here was you are monitoring the pressure, right? Fine. So I hope beta you would be able to identify that this instrument is actually used for measuring the pressure. Just by ankle brachial pressure index, we can come to know what is the severity of obstruction, right? So now let us see what all is written in this workbook here. Gradual arterial obstruction. Most common cause is atherosclerosis. However, even Burgess disease, that is thromboangiitis obliterans, can also cause this gradual arterial obstruction. The patient can present with, ध्यान से देखिए बेटा, look at the screen. There may be intermittent claudication in the beginning, then there can be rest pain, then there can be coldness, numbness, paresthesia, there can be pre-gangrene or there can be gangrene. right? Now, what is intermittent claudication, beta G? This is a cramp-like pain which is felt in the calf on walking. Felt in the calf on walking. Distance walked without pain. Distance walked without pain. This is called as claudication distance. क्या बोलते हैं बिट्टा जी? Claudication distance. ध्यान रखिएगा, this is not present at rest. This is only on walking. Usually felt in the lower limbs, but sometimes this S oblique T beta, this is sometime. Sometimes, if suppose you did not have the workbook and your surgery teacher would have been writing all this very fast, so what would have happened, beta? The demand by your fingers would have been more, the supply would have been less. So your fingers would have started paining. This is what we call as writer spasm. कभी कभी बेटा जब हमको बहुत जल्दी जल्दी तेज तेज लिखना होता है तो हमारी उंगलियां दर्द करने लगती हैं, लिखते लिखते दर्द हो जाए. This is called as writer spasm, right? Fine, beta. Now we can do a Boyd's grading here for intermittent claudication, and Boyd's grading, calf pain on walking, which improves with further walking. Improves with further walking. This is grade 1. Then calf pain on walking, patient continue to walk with pain. Continue to walk with pain. Calf pain on walking, now cannot walk, has to take rest. Has to take rest. Okay? And grade 4, rest pain. Rest pain is felt in the foot at rest. This is actually cry of dying nerves. The nerves which are situated in the skin of dorsum of foot, they are not receiving adequate oxygen supply. That is why the foot is paining. Gradually, beta, as the obstruction is increasing, there will be coldness, numbness, paresthesia in the foot. This indicates there is a major gadbad developing. There is a major issue, moderate to severe arterial insufficiency. Gradually, pre-gangrene can occur. This is a combination of rest pain, color changes, paresthesia, with or without skin ulceration. Rest pain, color changes. Why color changes, beta? अगर red hemoglobin नहीं पहुंच रहा है, if red hemoglobin is not reaching into the foot, so the foot area will become pale. Paresthesia. अच्छा बेटा, look at me on the screen एक बार. Look at me on the screen. This there are so many terms here, beta. Anesthesia. Aesthesia means sensation. Aesthesia means sensation. Anesthesia means no sensation. Hyperesthesia means more sensation. Hypoesthesia means less sensation. Paresthesia means altered sensation. Okay? So anesthesia, no sensation. Hyperesthesia, more sensation. Hypoesthesia, less sensation. Paresthesia, altered sensation. Okay. And obviously, if this oxygen is not reaching into the foot, there might be skin ulceration seen. And gradually, beta, gangrene can occur. Like what you are seeing here, this is dry gangrene. Can you appreciate how this has become black? There is no oxygen supply in this area, right? So all this area has become black. This is a dry gangrene, what we commonly see in arterial obstructions. While if suppose there is some infection, because of that some fluid will be present, and that is called as a wet gangrene. So this is something what we discuss in pathology classes as well, the dry gangrene and the wet gangrene. Right, beta? Gangrene is simply macroscopic death of the tissues. Right? Now, these are the different presentations. Let's take a look how you are going to approach your patients in practice February 23. You remember na beta what you are wearing in February 23? That white coat around your shoulders and stethoscope around your neck, right? Keep that fire in your belly. Keep that fire lightened up always. Right. So what we are doing, beta, we are doing the examination of the pulses. Which pulses we are examining? We are examining the femoral pulse, the popliteal pulse, the anterior tibial, the posterior tibial, and the dorsalis pedis. Now, in your anatomy classes also, these are discussed in detail. Femoral pulse कहाँ पे feel करनी है बेटा? 2 centimeter below the mid inguinal point. Popliteal is the most difficult pulse to feel. Popliteal is deep. There is no, or you write first this, there is no bony prominence. There is no bony prominence near the popliteal. And second, it is deep. Anterior tibial pulse. Anterior tibial pulse is palpated close to the tendon of extensor hallucis longus. Posterior tibial, this was a question on 4th of June. It's a repeat previous year question, beta. Discussed nicely by your anatomy ma'am. Between the posterior border of medial malleolus and Achilles tendon at inversion of foot. And dorsalis pedis, beta, once again I would like to tell you here, where is the dorsalis pedis? In the proximal half of the first metatarsal space. Because in the middle of the foot, this goes towards the sole. So we cannot feel for this in the distal half. We should feel it in the proximal half. So dorsalis pedis, this is palpated in the proximal half of first metatarsal space. Proximal half of first metatarsal space. Now, in arterial obstructions, beta, when there is a traffic jam in the artery, once again, let me remind you, beta, if this is the femoral, this is the popliteal, and these are anterior and posterior tibial, beta, then if there is a traffic jam in this particular area, what will be the nature of pulses? Distal to the obstruction. Distal pulses, since the blood volume has gone down, so distal pulses will be feeble or low volume. Low volume, or you can say feeble, or sometimes they can even be absent. Acha beta, what will happen proximal to the obstruction, beta? Here there will be more turbulence. So proximal to the obstruction, you can find a high volume or maybe normal volume. Whenever we are examining the pulses, we should always compare these pulses with the pulses of the other normal limb also. Apart from this, beta, there is a disappearing pulse. Disappearing pulse is due to collaterals. किसकी वजह से होती है ये? Collaterals की वजह से. On initial examination, the distal pulse may be normal. on exercise, the distal pulse disappear because the collaterals will not be able to supply the increased demand at exercise. So the blood is not coming properly in the distal vessels. That is why the distal pulse disappear. Now you ask the patient to take rest. At rest, again these pulses reappear. When we are doing the auscultation beta, we can hear a brew. Brew simply indicate there is a turbulence. This is due to stenosis or obstruction. And we can measure this ABPI. ABPI. This is ankle brachial pressure index. This is a ratio of systolic pressure at the ankle versus systolic pressure at the arm. If the value of this ratio is 1.1 plus minus 0.2, it means the story is normal. But if this ratio goes down, suppose I say that initially the pressure was 130 by 120. Right? So this is slightly more than 1, almost 1.1. Now, if the blood flow to the distal part has gone down, then obviously this ratio is going to decrease, right? So, suppose I say that the pressure in the distal part, suppose, has gone down to 100. Now, if you calculate this ratio beta, this would be somewhere around 12 6 are 70, 12 7 are 84, 12 8s are 96, then 40, 12 3s are 36, so 0.83 somewhere. If this ratio is less than 0.9, then this is a case of intermittent claudication. Intermittent claudication. That means the story has just started. But if suppose the obstruction has increased to such an extent that the pressure has gone down to say 50 by 120, now this ratio would be less than 0.5. This indicate rest pain. That means now there is a moderate to severe traffic jam which is developing. If this ratio goes down further, for example, suppose I say that this pressure goes down to 30. So 12 2s are 24 and 12 5s are 60.25 or somewhere around this. Then we say critical limb ischemia. Critical limb ischemia. And if the pressure goes down to say 10 or 12 millimeter of mercury, suppose 12 millimeter of mercury at the ankle, that means this ratio is 0.1. This is indicative of gangrene. This is indicative of gangrene. So beta, this ABPI is something which is so crucial in our clinical examination, and just by measuring the pressure we can come to know what is the status down. Right? So एक बार इसको याद करेंगे बेटा. Let us learn this ABPI. What is ABPI? This is a ratio of systolic pressure at the ankle to systolic pressure at the arm. 1.1 plus minus 0.2 is normal. Less than 0.9, intermittent claudication. Less than 0.5, rest pain. 0.3, critical limb ischemia. 0.1, gangrene. एक बार फिर से करेंगे बेटा. 1.1 plus minus 0.2, very good. Less than 0.9, less than 0.5, 0.3, 0.1. Let's do it again beta. 1.1 plus minus 0.2, less than 0.9, less than 0.5, 0.3, 0.1. Once again, let's do it beta. 1.1 plus minus 0.2, less than 0.9, less than 0.5, 0.3, 0.1. Very good. Now what we'll do is, we'll do it like this. 1.1 plus minus 0.2, less than 0.9, less than 0.5, 0.3, 0.1, 1.1 plus minus 0.2, less than 0.9, less than 0.5, 0.3, 0.1, 0.3, 0.3, 0.5 or less than 0.5, less than 0.9, 1.1 plus minus 0.2, less than 0.9, less than 0.5, 0.3, 0.1, less than 0.9, less than 0.9, 0.1, less than 0.5, less than 0.9, 1, 1, not 0.1, 1. 1 is normal, right? So 1.1 plus minus 0.2, less than 0.9, less than 0.5, 0.3, 0.1, wonderful bit. It's really good, really good. Great. Now, once we have done this clinical examination beta, we come to know the severity of traffic jam. To confirm our clinical findings, we can do a color Doppler. We can even do angiography. But angiography, we have to puncture the artery and then push the contrast. And whenever we are doing any puncture in the vessel, na beta, this causes endothelial injury. For example, if I just try to demonstrate you here, beta, if suppose February 23, you have got a needle in your hand and suppose you are making a puncture in the artery. Now, when you are making a puncture in the artery, beta, you can appreciate that you are actually causing injury here. And whenever there is an endothelial injury, you know pathology virtues triad. Endothelial injury, stasis, hypercoagulability. What happens? The platelets which are moving in the circulation, these platelets may come towards the site of injury and may start aggregating here, which can lead to thrombus formation. So whenever we are doing angiography, when we are puncturing the vessel, there is a risk of thrombus formation. That is why angiography is invasive. If we have got color Doppler, which is just an ultrasound, no invasion, and if color Doppler is giving us same information, then we prefer doing a color Doppler. So for the arteries, beta, the investigation of choice would be a color Doppler. Investigation of choice would be color Doppler. However, we should know that angiography is invasive. So that is not the preferred investigation of choice. However, if we do not have the facility of color Doppler, we can go ahead with angiography. This will tell us what is the site of obstruction, what is the status of collaterals, and what we are supposed to do. We can also do a Fontaine's classification here, where we can classify the presentation of gradual arterial obstruction into 4 grades. Grade 1 when the patient does not have any symptoms. Grade 2 when the patient is having intermittent claudication. Intermittent claudication. Grade 3, rest pain. Grade 4, gangrene. So according to Fontaine beta, grade 1, no symptoms. Grade 2, intermittent claudication. Grade 3, rest pain. Grade 4, gangrene. Grade 2 is further subdivided beta into mild and moderate. So 2A is mild intermittent claudication and 2B is moderate intermittent claudication, right? Chale. Now let's take a look. This is what we have understood. Okay, gradual arterial obstruction, how the patient can present to us in different stages. What you as a doctor will do to examine, clinically diagnose, and take the support of investigation to conclude your clinical diagnosis. Diagnosis is made. Patient is sitting in front of you. You are the doctor. As a doctor, what we want to achieve is we want to relieve the symptoms of the patient. You want to relieve the symptoms of the patient. So if you have to relieve the symptoms of the patient, beta, we can understand that we have to increase the distal blood supply. If there is a traffic jam here and the supply to this part is less, you are the doctor. You have to relieve the symptoms of this patient, and symptoms will be relieved if you are able to increase the supply to the distal part. अगर अपन नीचे की सप्लाई बढ़ा देंगे बेटा तो पेशेंट को आराम आ जाएगा ना, right? So how you can increase the distal blood supply? You try to create the bypass channels, encourage the body itself to create the bypass channels, encourage the body itself to form the collaterals. That means if you are able to form the bypass channels around the obstruction, if you are able to create the bypass channel around the obstruction, then the blood will be diverted and the supply to the distal part will increase. How we can encourage the patient to develop the collaterals on its own? We ask the patient to modify the lifestyle. Why this cholesterol is depositing? ये मक्खन जम क्यों रहा है आर्टरी के अंदर? क्योंकि पेशेंट स्मोक करता है, पेशेंट दिन भर बैठा रहता है, पेशेंट मोटा होता जा रहा है, पेशेंट की डाइटरी हैबिट ऐसी है कि सुबह भी पराठे पे मक्खन चाहिए और शाम को भी मक्खन चाहिए. Why this obstruction is taking place? Why atherosclerosis is taking place? Patient is a smoker, patient is obese, patient is sitting all the time, patient is having the habits wherein he is taking more amount of cholesterol in his diet. So that is the reason why this cholesterol is getting deposited. You ask the patient, Bhai Sahab, hello, Bhaiya. You tell the patient, what the hell you are doing with your life? Why you are smoking? Stop smoking. Why you are sitting continuously? Why you are increasing your weight? Do brisk walk 40 minutes in the morning, 40 minutes in the evening. And don't take so much of cholesterol in your diet. Right? This cholesterol is getting deposited in your artery. One day your artery will get blocked. And then nobody will be there to supply blood to the distal part. And then what you will do? You will develop gangrene. And then what will have to be done? We have to amputate. Do you like amputation? Patient is listening. Patient sun raha hai. Then he tells you, yes doctor, you are right. I will change my lifestyle. Right? Patient goes out of your chamber. He starts thinking, doctor is right. I need to change my lifestyle. Then he goes to a cigarette shop, buys cigarettes, starts smoking. I have to change my lifestyle. I will do that one day. And unfortunately, that day never comes. And the problem persists, keeps on increasing. This lifestyle modification, what we have told to the patient, this is really expensive. Patient can't afford this lifestyle modification. That is why there is a problem. Now patient keeps on coming to you, doctor, I'm trying this, I'm trying that, but I'm not getting any relief. I've heard that you have done your graduation from out of India. So you would be knowing all the stories. I've tried so many Indian doctors, but nobody is able to help me. You can do something. Now you are thinking that this patient is not responding to the lifestyle issues. What I can do, I can try giving him some medicines. You can try giving him some vasodilators. You can try giving some antiplatelets. You can try giving some statins just to promote the increase of blood flow in the distal part. But results of these medicines is also not good, not very encouraging. So you start thinking, I should do something to increase the distal supply. We just want that whatever is this obstruction, we want the distal supply to increase. If you are able to increase the distal supply, the ischemic symptoms will disappear. So you start thinking, okay, what I can do is I can think of doing something like this. Now, what is this something here? Now, here what we are seeing, beta, we are just seeing that this is the artery and this is the makhan which has got deposited here. This is the cholesterol which has got deposited, right? Because of which the lumen has become narrow. So the distal supply has decreased. We want this lumen to dilate. So what we can do, we can take the help of a MCQ catheter, Fogarty catheter. We pass a guide wire first. The guide wire is being passed here. Now we pass a Fogarty catheter which has got a balloon. Keep the balloon at this side. Inflate the balloon. Now by inflating the balloon, you have dilated this vessel. Remove the Fogarty. Remove the guide wire. Repeat the same procedure again. Repeat the same procedure again after 1 minute. Again pass the guide wire, again pass the Fogarty catheter, keep the balloon here, inflate the balloon, and this will help in dilating the stenosis area. Now remove the Fogarty catheter, then remove the wire also. So you can see the lumen is being dilated and the distal supply is increased. This is a simple balloon angioplasty. Angioplasty. We keep on talking about these angioplasties. This is how simple the angioplasty is. This is simply a balloon angioplasty. But if you have not put a stent in this area, there is a risk that this restenosis can occur very fast. To avoid restenosis, we can put some stent in this area. We can put a stent in this area. We can put a simple metallic stent, but the problem with a metallic stent is the wires in that stent, they encourage aggregation of platelets, and maybe over a period of time, maybe 2 years, 3 years, 5 years time, the platelets, fibrin, etc. get deposited on the wires of the stent and the stent gets occluded. So nowadays what we are using is special type of stent which are drug-coated stents, sirolimus-coated stent. These drug-coated stents do not allow the adherence of platelets and all onto the wires of the stent. So the stent remains patent for a longer period, right? This is a stent angioplasty. If suppose the facility of angioplasty is not available and we have to treat this patient. Now, in order to treat this patient, what we can do is we can do some surgical intervention. We can just do some surgical intervention and try to treat this by some surgery. What we can do here is, if the body is not able to form these bypass channels, beta, if the body is not able to form these bypass channels, then we can form these bypass channels around the obstruction. Not this, not like this. We can form the bypass channels by surgery, and that is what we call as a bypass surgery. Now from where we are going to get this bypass graft? We can take this graft from inside the patient. which we call as autologous. And this arterial graft would be a better than venous graft because artery is strong. Artery media has got muscles to tolerate high pressures. So we prefer using a arterial graft. Earlier we were preferring using a great saphenous vein graft. Now we are preferring a internal mammary artery graft. Now this was also a question on 4th of June 2022. Which graft will have long-term patency? The answer was internal mammary artery. Okay, this is something what we are commonly using. Right. The left and right internal mammary arteries can be used. We can use gastroepiploic artery. Anything which is taken from inside the body is an autologous graft. However, beta, these graft what you're seeing here, they are also available in the market, synthetic graft. These grafts which are available in the market may be made of some textile material or non-textile material. Like if I remove myself, beta, herein, these are synthetic grafts what you are seeing. They are available at the chemist shop, right? These are made of textile or cloth material, Dacron graft. These are also available as non-textile material that is a polytetrafluoroethylene graft, PTFE graft. टेक्सटाइल वर्सेस नॉन टेक्सटाइल, बेटा ये बताना जरा कौन सा अच्छा होगा, कपड़े वाला या बिना कपड़े वाला? विच ग्राफ्ट विल बी बेटर, टेक्सटाइल और नॉन टेक्सटाइल? टेक्सटाइल ग्राफ्ट इज बेटर. एंड दिस टेक्सटाइल ग्राफ्ट, जो कपड़े का ग्राफ्ट होता है ना बेटा, दिस टेक्सटाइल ग्राफ्ट कैन आइदर बी वोवन or it can be knitted. So knitting, just like the sweaters are knitted, and woven is by a machine, weaving machine. Okay, so woven grafts are better than knitted graft. So this is how we can do these bypass surgeries. Now let's see what all is written in our workbook. In the treatment of this beta, our aim is to relieve the patient's symptoms by increasing the distal blood supply. In the treatment beta, you have got 4 options. 1, lifestyle modification, another medicines, another angioplasty, and another surgery like bypass surgery. In lifestyle modification, you are advising the patient to stop smoking, reduce weight, brisk walk for 40 minutes. 40 minutes in the morning and 40 minutes in the evening. It should be a brisk walk, beta. It should not be a lazy evening walk after dinner. And it should not be a story like Bhag Milkha Bhag. Right? Patient should not run also. We are just giving gradual load so that the body is trying to form these collaterals. And believe me, beta, if the patient can afford this treatment, if the patient follows your advice, there is an improvement seen in 6 months' time due to formation of good collaterals around the obstruction. Obviously, collaterals are something which take a long time to develop. 6 months' time, good collaterals can develop and the patient can be absolutely fine. But this treatment is really expensive. Patients can't afford. So we might have to give some medicines like vasodilators, antiplatelets or statins. In vasodilators, we can give cilostazol, we can give oxypentyphylline. In antiplatelets, we can give aspirin for long term, clopidogrel for short term. We can also use statins. We can do angioplasty, which we call as PTA, percutaneous transluminal angioplasty. The catheter which is used in vascular surgery, the name of this catheter has been asked twice in the last 4 years. Fogarty catheter. Fogarty catheter is used in vascular surgery. By this, herein, as you can see beta, this is the Fogarty catheter. Can you appreciate the balloon? This is the collapsed balloon state and this is the inflated balloon state. We can do a stent angioplasty. There are simple metallic stents, but they are not used now. They are drug-coated stents which we are using now. The drug which we are using here is sirolimus. Sirolimus coated stents are used. When we are doing this angioplasty for coronary artery, we use the term PTCA. This is percutaneous transluminal coronary angioplasty. Percutaneous transluminal coronary angioplasty. And the fourth option which we have is surgery. In surgery, we can do bypass surgery, that is a bypass graft. In this bypass graft beta, we have got the option of choosing an autologous graft or a synthetic graft. Autologous grafts definitely would be better. These autologous grafts can be great saphenous vein. This can be lima rima, जो अपनी lima rima है, left internal mammary artery, right internal mammary artery. So we can use internal mammary artery. Internal mammary artery, left or right. And we can use this gastroepiploic artery. For long-term patency, we prefer using arterial graft, and here we prefer using internal mammary artery. Internal mammary artery. We can also use synthetic grafts which are available in the market, and these synthetic grafts available in the market can be textile, non-textile. Textile means cloth, right? So textile grafts are better, Dacron grafts are better as compared to non-textile. Non-textile is PTFE, that is polytetrafluoroethylene. These textile grafts beta, they can be either woven or knitted. In this, woven grafts are better than the knitted graft. Woven grafts are better than the knitted graft, right? Fine. Whenever we are putting these grafts, there might be some problems which we might face at times. For example, most common cause of early graft failure. Whenever we are using this bypass graft beta, the graft can fail. Initially, it is the fault of the surgeon, faulty technique. Most common cause of late graft failure. This is graft occlusion. this is graft occlusion. Most common cause of graft infection. Most common cause of graft infection, it is by Staph aureus. Staph aureus. Most common cause of graft infection. This is by Staph aureus. To summarize better, that which type of procedures should be chosen. Now suppose here we say that we are talking about the abdominal aorta. Suppose is the abdominal aorta, and we know this abdominal aorta bifurcates into common iliac, which further divides into internal and external iliac. So internal goes towards the pelvis, external goes towards the lower limb, right? This external iliac then becomes the femoral, and then this becomes the popliteal, and then this popliteal further divides into anterior and posterior tibial. Something like this. Now, if we just try to focus beta in this area, this pinky thing what you're seeing here, this is the inguinal region. If there is a traffic jam in the artery above the inguinal region, that is traffic jam in the suprainguinal region, then we prefer using a Dacron graft here, aortoiliac obstructions. If there is a iliofemoral obstruction, then we prefer doing a angioplasty. And if it is a infrainguinal, the green area what you're seeing, infrainguinal, we prefer using the great saphenous vein. That is femoropopliteal, we prefer using a great saphenous vein. So if there is a aortoiliac obstruction, that is suprainguinal obstruction, then what we are using is a Dacron graft. If there is a iliofemoral obstruction, that is inguinal obstruction, then we are doing angioplasty. And if there is a femoropopliteal obstruction, that is infrainguinal obstruction, then we are using the great saphenous vein graft. Great saphenous vein graft. Right, beta? So this is how we are actually treating the arterial obstructions. You can use lifestyle modification, medicines, angioplasty, or bypass surgery. Right? This is how we can promote the increased blood supply to the distal part and relieve the patient ischemic symptoms. Sometimes we come across situation where, like Burgess disease, which is a disease of small and medium-sized vessels. Now, suppose we talk about, say, Burgess disease patient. Burgess is something which is seen only in smokers, and this is a disease of small to medium-sized vessel. Burgess disease is a disease of small to medium-sized vessels. That means here. So if there is a disease of these vessels, right, seen only in smokers, patient usually complains of rest pain to us, rest pain in the foot. We try to treat these patients by lifestyle modification, but they don't quit smoking. We try to give them some medicines, not very useful. We try to do angioplasty. But for angioplasty, you saw that we have to pass a balloon catheter. We have to first inflate the balloon at the site of stenosis, and then we have to put some stent. But if we are talking about a small vessel, then the Fogarty catheter will not go easily here at the site of stenosis. So angioplasty may not be possible. Same thing, bypass surgery may not be possible in these very small vessels. That means the option in the treatment for Burgess disease patient who are coming with rest pain is just a lifestyle modification or some medicines. Now, if the patient is not improving, if the patient is not following your advice, and patient is continuously asking questions, Doctor Saab, I have shown to so many Indian doctors, nobody is able to treat me. You have come from outside. I know you can do something for me. I am having this rest pain. Though you bluntly tell this patient, you can either have your cigarettes or your legs. या तो भैया पैर बचेगा या बीड़ी बचा लो. But the patient chooses cigarettes. So, in order to relieve the rest pain of this patient, what we can do is, we can do a lumbar sympathectomy. In lumbar sympathectomy, beta, what we are doing is, we are actually making an incision in the lumbar region. And then we remove the lumbar sympathetic chain here. There is first, second, third, fourth lumbar ganglia. We remove this lumbar sympathetic chain. By doing a sympathectomy, the arterioles in the foot, they get dilated. I repeat, beta, by doing lumbar sympathectomy, the arterioles in the foot, they get dilated. Now, if they get dilated, they want more blood. Calf is the most bulky area. If the arterioles dilate, they will steal blood from the calf. So, after lumbar sympathectomy, when the arterioles dilate, they steal blood from the calf and the calf blood goes towards the foot. If more blood comes in the foot, then rest pain will be relieved. So, lumbar sympathectomy can relieve the rest pain because foot arterioles dilate and they steal blood from the calf. More blood comes in the foot. Rest pain is relieved. But if by chance the patient had intermittent claudication, that is calf pain, and you do a lumbar sympathectomy, the calf pain will increase because after lumbar sympathectomy, the calf blood is going towards the foot. So blood in the calf is decreasing. If the patient was having calf pain already and blood is decreasing, the calf pain will increase. So lumbar sympathectomy should not be done in intermittent claudication. It is done in rest pain, right? Lumbar sympathectomy, beta, this is simply removal of first, second, third, fourth lumbar ganglia. By doing a sympathectomy, the foot arterioles, they dilate. So blood starts moving into the foot. So foot pain is relieved. That means this is indicated in rest pain. But since calf blood is going out, and if the patient was having calf pain will increase. So lumbar sympathectomy should not be done in intermittent claudication. If the patient has already developed gangrene, then for gangrene, we do amputation. Long back in one of the exams, 10 years back, there was a question that out of the various treatment options in arterial obstruction, which treatment gives best pain relief to the patient? Answer was amputation. ना रहेगा बांस तो कैसे बजेगी बांसुरी, right? चलिए बेटा, so this is all about the gradual arterial obstruction story. I hope you have got the concept nicely, how that atherosclerotic plaque starts developing, how the patient presents to you with different stages, intermittent claudication, rest pain, coldness, pre-gangrene, gangrene, how you have to approach these patients, examine the pulses, distal to the obstruction, low volume, proximal to obstruction, high volume, disappearing pulse because of collaterals, auscultation, brew indicate some stenosis, turbulence. ABPI, ankle pressure versus brachial pressure. 1.1 plus minus zero point 0.1, 1.1 plus minus zero point 0.2 is normal. Less than 0.9 intermittent claudication, less than 0.5 rest pain, 0.3 critical limb ischemia, and 0.1 gangrene. Right? Color Doppler, investigation of choice. You know there is an obstruction here. In the treatment, you have to increase the blood supply to the distal part. Lifestyle modification, promote the formation of collaterals. Medical treatment to increase the blood flow. Angioplasty, again to increase the lumen, to increase the blood flow. Bypass surgery, you can create a bypass channel for diversion of the blood and increase the blood flow to the distal part. Sometimes we have to do a lumbar sympathectomy in Burgess disease in rest pain cases and amputation in cases of gangrene. So this is the whole summary of today's discussion, beta. The rest of the things we'll be discussing tomorrow morning at 9 o'clock. Before we close down, beta, just to remind you once that the entire game is for that fire in your belly. It is not the duration of study which will matter. It is the intensity of study which will matter. It is the focus and concentration what you can put in for these 4 months and 20 days. Right? खुद को कर बुलंद इतना कि तकदीर बनाने से पहले खुदा तुझसे खुद पूछे बता तेरी रजा क्या है। एक बार फिर से बोलता हूं बेटा, खुद को कर बुलंद इतना कि तकदीर बनाने से पहले खुदा बंदे से खुद पूछे बता तेरी रजा क्या है। Just to convert this in English, beta, make yourself so much strong that before your destiny is written by God, let God ask you, tell me what you want. I repeat this. Make yourself so strong, so focused that before writing your destiny, let God ask you, tell me what you want. And you will be getting the exact same thing what you want in your life. Just remain dedicated, just remain focused, just remain pumped up, just remain positive. Keep on helping others, keep on motivating others, keep on doing good things for others. Never say anything bad about anyone. Never have any negative people around you. The world will be yours and sky will be your limits. Thank you very much for your patience. Have a great evening ahead. May God bless you all. See you tomorrow morning. Here, I'm taking a break of approximately 20 minutes and I'll continue the link here. I'll be answering your queries after 20 minutes, right? And I'll be using that speaker mode in the WhatsApp also. So if you don't want to listen to all the queries, you can just type your query on my WhatsApp and I'll respond to you with the speaker on as well as in the live. Thank you very much. May God bless you. Good night. Right, beta. So now let's take a look at the queries, what we have. Let me first look at the chat in the batches. So I am not able to see any chat in the batches. Right. So let me go into the WhatsApp and let me start taking the queries from the beginning where we left. Shinu from KNMU beta, diabetic ulcers would be having the inflammatory sloping type of edges. This is Hema from Stavropol beta, a lady with 50% burns of dermis and subcutaneous tissue came to emergency. Burns will be classified as 3rd degree. This is a 3rd degree burn beta. Priyanka from Karasim beta, the treatment of pilonidal sinus. We advise lifestyle modifications. We advise patients to avoid sitting for long periods, avoid uncushioned seats. We advise the patient for dressings if there is any oozing or something coming out. We can give antibiotics if there is secondary infection. However, the definitive treatment would be excision and leaving it open to heal by secondary intention. Or we can do plastic surgical reconstructions for this pilonidal sinus. But the chances of recurrence after treatment are high. This is Dimahi from OLFU. Very good day to you, sir. Can you please tell how do we treat pilonidal sinus? I hope that you have just heard the conversation what I had. I'll just copy the audio message to you if you are not in the live class right now. Just a moment. 78506. Pressure ulcers, diabetic foot, generally they are the healing ulcers. So we find those sloping edges there. Pranchal from Belize. Sebaceous cyst treatment is simple excision. If it is infected, then first we give antibiotics, treat the infection, and then we go for excision of sebaceous cyst. This was a query from Jay Davao. The query is from the last digits 6 to 555. Diabetic beta, please do mention your name and university. Diabetic peripheral neuropathy is due to arterial obstruction. Diabetic peripheral neuropathy, yes, there is decreased blood supply to the nerves. So in diabetes, actually there is both arterial as well as venous obstruction. Class salary. The last 5 digits 91181. Divyansh from Orenburg. These chantings are amazing. Please keep doing them. Thank you for putting so much effort. Thank you very much, Peter. God bless you. May you just keep on focusing yourself, and may you just keep on doing the good work, and may you come out with flying colors. Abhiti from Davao, beta. Do sinus and fistula are both common in males and seen among 20? No, it was only for pilonidal sinus, beta. The 29 years. Treatment of sebaceous cyst is surgical excision, beta. If by chance they are infected, first we treat the infection and then we do excision of sebaceous cyst. Thank you, Shlok. Thank you so very much, beta. God bless you, and may God give you all the courage and power to fight these 4 months and 20 days out with great zeal and determination. May God bless you, Shlok. Thank you, beta. Thank you very much. Please do mention your name and university. Thank you for your kind words of appreciation, beta. Thank you so much, beta. Thank you so much. Please do mention your name and university, beta. Okay, you are Abhijit from Davao. Thank you. Haley from Northern State. Does deep vein thrombosis causes enough blood pooling to cause neurogenic shock? Not usually, because there is a diverted channel from where the venous return can occur. Anish from KNMU beta, the cry of dying nerves is when the blood supply is not going into the nerves which are present in the skin of the dorsum of foot. So they start shouting that they want blood. So it is something like that. This is a term which is mentioned in the standard textbook of surgery, Bailey and Love, cry of dying nerves. So I thought to include this in the discussion beta. Devika from Irkutsk, color Doppler beta, this is just a ultrasound. Color Doppler is much more accurate than handheld Doppler. Color Doppler is a ultrasound. Now ultrasound, there can be a gray scale ultrasound, which is a B scan ultrasound, and there is a color ultrasound. So here we can use the colors like the blue and the red color. The flow which is coming towards the vessel, that is red. Flow which is going away from the vessel, that is blue in color. Doppler is something related to sound. Whenever we want to hear the velocity of flow, we take the help of this Doppler. So addition of both is color Doppler. Color Doppler is much more accurate than handheld Doppler beta. Yes, Ragul from Venezia. One doubt, which is best treatment, angioplasty or surgery? Because we are using drug-eluted stents and we have surgery, and why so? Basically, beta, there are situations where we cannot do angioplasty. Maybe some facilities are not available at some centers, at some places, but surgery facilities are there. We can do bypass surgery there. When we are doing a bypass surgery, definitely this has got more risk of complications as compared to angioplasty. So we have to weigh the pros and cons. Why we are doing angioplasty in inguinal region and not surgery beta? Because in inguinal region it is the pelvic area and surgery becomes difficult in the pelvic area. So we prefer doing angioplasty in the inguinal region. You did not understand the synthetic graft beta. Synthetic is something which is not natural, which is not taken from inside the body, but it is made artificially. It can be made from a cloth material, that is textile, that is a Dacron graft. It can be made from a non-cloth material, and the substance we use is PTFE, polytetrafluoroethylene. Now in textile grafts, they can be knitted or woven. Knitting is something which the mothers have been doing for a long period for all of us beta. They are knitting the sweaters for us. So the same way the cloth can be knitted. Or the cloth making factories, the machines are making the cloth. So they mainly use that weaving story. Now, if you compare the mother's hand sewn sweaters, they will have larger pores, while machine cloth will have lesser pores. So the chances of leak by a weaving graft would be less as compared to the knitted graft. That is why woven graft are better than knitted. Anindita from Kiev beta, according to Fontaine, up to which level interval will be mild and moderate? Till the time the patient is able to walk without any discomfort, when he don't have to take any rest. That means Boyd's 2, that will be mild, and Boyd 3 would be moderate. In Boyd 1 beta, when the patient start experiencing the pain in the calf initially, that is because of accumulation of substance P. Now, when the patient is walking for more distance, there is a vasodilatation which takes place. And sometimes because of that vasodilatation, whatever substance P got accumulated which was causing pain, because of vasodilatation, suddenly the blood flow improves and the substance P is washed off. That is how the pain is relieved, and that is what is Boyd 1. Aditi from Yangsu beta. The surgery classes videos will be shared later also, and maybe we might have to repeat the surgery live classes again in the month of October, late October. Your surgery will not be weak, bitter. This is my assurance to you. We'll make some alternative arrangement. Do not worry, bitter. Take very good care of your family at this point of time. I'm sorry, I'm in the class right now and I did not see your last message. After doing sympathectomy, generally there are no complications, but if you are doing a lumbar sympathectomy on both the sides, then yes, if you are removing both the first lumbar ganglia, then patient can develop impotence at times. Usually, the initial 6 weeks is what we take as early. Asked from Our Lady of Fatima, beta, patient had complained of having pain in the thigh due to heavy sunlight exposure, but no sunburn notice in thigh. What can be the treatment? What other causes can be possible? I don't think any treatment would be required in this case because this would be a transient thing. Might be due to some inflammation in the muscle, and this should settle down spontaneously within 5 to 6 days. Chronic sinus very rarely can become a fistula, yes. The last 5 digits 0 to 5 to 6. Please do mention your name and university, beta. I think I have missed out on that. Is pain due to exercise normal or due to lactic acid, or it can also come under grade 1? It can be normal also if you are doing vigorous exercise. It can be due to exertion also due to accumulation of lactic acid, or it can be due to arterial obstruction also, and it can come under grade 1 as well. Vignesh from Davao, good evening to you, beta. Keloid needs to be treated with a small, like 1 inch. Yeah, it's better to treat that. Generally, there is nothing serious if the keloid is left untreated, beta. Samim from Osh beta, sir, about great saphenous vein for femoropopliteal obstruction. Since great saphenous vein is located close to the femoral vessels, or you can say it is located next in the thigh, so it is easier to take a great saphenous vein whenever there is a femoropopliteal obstruction. That means if there is atherosclerosis, say in the distal part of the femoral artery or maybe proximal part of popliteal artery, then we can do a great saphenous vein bypass graft. Femoropopliteal is the commonest peripheral bypass surgery done, beta. Foot arterioles, we cannot do angioplasty at all, beta. They're very small. So lumbar sympathectomy, yes, you are right. Substance P, beta. P for Papa. Substance P. Substance P is the substance which is responsible for pain, beta. Kapil from Karazina, beta. What's the difference between spontaneous pneumothorax, tension pneumothorax? Spontaneous is, which is spontaneous, like related to emphysematous bulla. Yes, you're right. Emphysematous bulla rupture are commonly related to spontaneous pneumothorax. But if there is massive amount of air getting collected, it can also cause tension pneumothorax, Kapil. Yes, temporary ice application for pain may be helpful. You can do that initially. Thank you, Vignesh. Thank you so very much, Peter. Thank you very much for your patience, Peter. May God bless you all. This is all about the queries for today. May God bless you. Have a great night.